The topic given this time is about the investigations and try to understand with the Ayurvedic principles. Of course, it's a very challenging issue. There may not be any absolutely correct answer to these questions, that cannot be. But I will try to just share my examples, how I deal with those investigations, how I take the benefit of those investigations in prescribing Ayurvedic medicines. Now, of course, let me start with some basic introduction. Of course, the investigations basically they are done with a specific purpose. The specific purposes which are supposed to be ideal purposes which are supposed to be for the investigations could be either to screen a possible disease in a community, if there is a possibility of disease or not, or screen to determine the risk of developing a possibility of disease, like those who are prone to have that. Otherwise, either genetically or sociologically, if there is a community which is prone for certain disease conditions, to screen that investigations may be necessary. Or if we have already a patient, a person has become a patient, has come to the clinician, so to confirm your diagnosis, that's one of the important issues. If a probable diagnosis is made and then the diagnosis is to be confirmed, you may need some specific investigations. Or when a physician has two or more than two of these alternate possible diagnoses, to confirm any one of that, rule out the diagnosis, you may need the investigations. And once the treatment is started, maybe to select an option for the treatment, some of the investigations are required. These examples I will just deal with when we go on further into this series as it. Then once the treatment has been started, to see whether the patient is responding properly to the treatment or not, or whether there is a need to modify the treatment, you may need an investigation. Or to stop the investigation, like whether the patient is completely cured of the disease or not, to confirm that you may need an investigation. Of course, whether the selected option of the treatment is sufficient enough, or there is a need to change the option of the treatment in middle over, that also could be one of the purposes of these investigations, to predict like whether the patient is possible to be cured or not, prognosis of the disease. So you have many reasons to do the investigations in a clinical setup. Next, now, just one push. Now, this same issue is from the Ayurvedic text. Now we have these were classified or step-by-step protocols, but what the Ayurvedic text would be same. Aisha pramana jnana heturva or baladosha pramana jnana heturva तावद्यं बलदोष प्रमाण ज्ञान हेतोः दोषमाण अनुरूपो हि भेषजमाण विकल्पः विशेषापेक्षः भवति. So select the right drug, you need that specific method of examination. Though Ayurveda doesn't mention about these laboratory investigations, but there is a protocol of going for a higher level of the examination. Next slide. Now, type of the clinical investigations now which are available. From Ayurvedic point of view, of course, there is a bit of overlapping issue. From the current point of view, from the clinical aspect, any approach to a disease would always should start with a clinical diagnosis. So initially you will have to examine the patient. Darshana, Sparshana, Prasna, those are the issues. You will have to examine the patient, collect the physical signs. That's the most important critical first step in the dealing with the patients. Without that, going to the investigations is not really justified. Then of course you have the options like imaging studies, microscopic studies, biochemical studies, functional studies of different organs, and microbiological studies. Now maybe as per the present plan, probably we may have this series of sessions like where we will deal with some of those issues. For today I will limit only to hematological investigations for today. Now these are certain of those varieties of the investigations or groups of the investigations which are done regularly. Next. Now the target of the clinical examination mentioned in the Samhitas has almost a similar resemblance, though the technology is missing. All that what we have now is an additional technology, and the technology has modified those outcomes, rather enhanced the scope reach there. But basically the issue is same, that ataram pariksheta prakrititah vikrititah saratah samhanatah pramanatah and Satmataha, Sattataha, Ahara Shaktataha, Dashavida Pariksha. I think these are all the issues which are already learned and then forgotten also. Now, so that Dashavidha Pariksha is a form of an alternative to these possible investigations. Because we have missed that link of doing such examinations thoroughly, we need the laboratory investigations now. Next. Now, next. The basis of clinical examination in those days in Ayurvedic textbook, so I will limit only very few issues related to that, our text, then I will come to the contemporary, so don't get bored after. The concern about the disease should start the moment a physician gets a message that a person is ill. So that's Duta Nimitta Shakunya. So starting with that moment, that kind of an involvement with the patient and disease is the ideal setup for a physician, which we are missing now. So one of the important things which can avoid those need of battery of investigations could be that kind of a commitment where you have that intention to treat the disease, have a concern about the disease. The moment you get certain message that a person is diseased, then the whole examination in those days, Charaka or Sushruta, what doing is they would go to the patient's home, examine. During the passage to the home, because of the concern of the patient, the physician would say like, he can identify certain of those things which can predict the prognosis, outcome of the disease. When a physician could see certain of the plants or sources of medicine which could be used for the treatment of that disease, that's a Shubha Shakuna. If it is not so, then it's a Ashubha Shakuna. And by looking at the personality of a messenger, the seriousness of the disease could be measured. So that kind of a concern to the patient is what we now miss. We do not have that kind of a commitment now. And in the present day situation, most of the times it's the patient coming to the physician than really the physician going to the patient. So the whole situation is topsy-turvy, and that's exactly the reason why we need these high technology investigations as and next part. Now, the basic method of clinical examination starting in Samhita, particularly Sushruta, would be when you examine the, and this is absolutely true, even though we have so much of the investigations now, still the basis of the clinical examination would be by identifying the part in which the disease is seen by a physician. Unless the physician makes an idea of which organ of the body is suspected to be having the disease, investigations would be meaningless. And that's exactly the basic would be Yasmin Stodadayo Deshaya. The possibility of the lesion would be identified by getting the information by the patient, and then you will have the series of clinical examinations by which the disease can be identified, like Aturashchapyam Desham Abhiksham Parirakshati. In the current medical term, we have a big term called Decoding diagnosis. By looking at the position of the patient, you can predict that certain of the diseases are there. The same is what Sushruta would say as Abhikshanam Desham Parirakshati Samakshmanaha Bhushaha Pradarshadam Nidesham. Next part. And ultimately, to say whether there is an abnormality or normal, you have the identification of the color variation. Shuklanam Krishnatvam, Krishnanam Shuklatvam, a part which has to be black, which becomes white, or the other way, or Raktanam Anyavranatvam, that the color of the body contents, maybe the body fluids, blood and changes, right? Now those days they had certain means of identifying the color changes which we are missing. Now according to Sushruta, the color flowing in Vatajasira would be having a bluish color, Pitta-jasara would have a reddish color. Now whether those colors variations can be really made out with our naked eye, now it's not possible. But maybe it's because our eyes have lost that capacity, we need the instruments. Now we have many instruments which can identify these color changes. That's exactly what I am just going to deal with in the next variations as it. Or Dirganam Hrustatvam or Achalanam Chalata, those parts of the body which naturally have a movement, if they do not have the movement, or a part of the body which is not supposed to move if there is an abnormal movement, that's all the basis of the clinical examination. We will have lots of tests like named with the different names as you have that Perthes test, you have that McBurney's test and so on. You give lots of different names which make the whole study of medicine difficult rather. But basically all of that would be the same, identifying an area where there is a tenderness or pain with some specific positions or abnormal movements. Pruthuram, Sankshitanam, Pruthuram, variations in the size, you see, hepatomegaly, and what Sushruta says is the same, like the size being bigger than the normal, and then Apatana Dharminam, Patana Dharmipur, those who are not supposed to fall off by itself, persons who otherwise stable structure, if it becomes unstable, that stability of the area, or Shaitya Ausnya Snaigya Rauksha Prastamba Vaivarnya Avasadhanam, the different qualities of the areas of the body or structures of the body, that's exactly the same variations of the color and so on. So the same is the cheese is our basis of all the investigations. Now all that would be, all the investigations which we now do, all that series of investigations starting from imaging to biochemical, they do the same function. The only thing is, because of the technology, the accuracy of those observations are enhanced. That's exactly the point which I try to highlight in due course of time. Like the basic idea of the investigations or basic principle of the investigations which you do with a lot of technology is aimed at the same, like identifying the variations, but these are identified with the more accuracy, more standard methods. And what we miss in our text would be, you do not have that standard protocols which are described. We have missed it. Probably at that time, they had that protocols which we have missed. And it's an unfortunate situation for us. Next. Now, a bit of extension of the same logic. Whether these methods of examination were established at that period or not. Of course, you know, the whole Padartha Vijnana subject, you start with the Vaisheshika Darshana, and in the Vaisheshika Darshana, the examination would be having the Sankhya, Parimanani, Prataktam, Sniyoga, Paratva, Pakatve, Karmacha, and it could be Chakshushani or Arupani, Atakshushani, those which are visible to the naked eye, but there was some method at that time by which the atakshusha, those which cannot be seen with the eyes, also were identified. And for that, the atakshusha pratyaksha, either yogaja pratyaksha or arshajnanam or siddha darshana. Next. Now, the siddha darshana, the description of the siddha darshana in Kannada, the Vaisheshika darshana is the Paramanvadi darshanam. That's what we now do with the microscope. Those days, they had that capacity to identify that microscopic objects like Paramanu. So Paramanvadi Darshanam, of course, is the same. Now you have advanced technology to identify that. Or Hrutla Kuharaschitasya Atmasya Jnanam, that big line, I just selected one single word to make it convenient. That's exactly what we do with the endoscopy. You go into the body, identify the structures, again with more accuracy, more sophisticated approach, or Suryamani, Chandramani Adina Vishesha, having that extra or variations of the light source, different source of the energy, Chandramani, Suryamani, with that you just look at the object and make out. All that imaging studies, X-rays and so on, they are the similar issues. I don't say they are the same, but that kind of an approach was there. Or clinical biochemistry, where Samaveta Samavaya Bhava, interrelations between the different molecules, chemical properties of that, how one combines with the other. Samaveta Samavaya is one object combining with the other. That kind of a property being mentioned, that's about the Samaveta Samavaya Bhava. Now, when I say this, I don't mean to say that Ayurveda has everything. No, that's not the target. The point is, the most important point is, we have lost a big treasure, and it's unfortunate. So I am not claiming the pride that Ayurveda had everything. Rather, I am just saying this, that with a sorrow figure, like we have lost that treasure. So that's all the point. So don't put it the other way, like I have just boasted about Ayurveda. It's not boasting about Ayurveda, rather a criticism on ourselves. Next. Now, in the present day situation, I skip over again, instead of wasting much time on the basic issues. In the present situation, one of the significant issue in the medical practice and issue of concern throughout the globe is use of unnecessary investigation. In 80s, when I was a student, there was a system of medical audit, and that medical audit system would be the list of investigations done by a physician would be reviewed. If any physician would have more than 50% of the investigations being negative, he would be warned that he is doing unnecessary investigations. If the investigations done by or suggested by a physician would be having more than 75% positive results, then only he would be considered as a better physician or better practice. So investigations were used sparingly and only after making a probable clinical diagnosis. But the situation in the contemporary medicine has changed a lot. Now there is a whole practice is based upon what we call as evidence-based medicine, and most of the times you will have only evidences, no medicine, no patient. That's the real situation. And in terms of this identifying the evidences, most of the patients, by the time the investigations are over, they would not have any resources to continue the treatment. They end up in Ayurvedic hospitals later. And particularly, jiska koi nahi hai, uska to SDM hai yaro. So most of the patients who come to our hospital are of that category, but they have lost the fortune and they do not have anything to maybe continue the medicine. And at that patient situation, they may come with a huge setup, the big pile of investigations, and that unnecessary investigations is not only a problem which we face, globally it's a problem. WHO has concern, and the WHO, I just copied it from the WHO site, the possible reasons why the over-investigations or unnecessary investigations are done. Of course, WHO gives many reasons from the global point of view. Again, I will not read that. I have highlighted one issue, the remuneration models of ownership diagnostic equipment, which is the reality now amongst our. So when I criticize, it's not that I am criticizing the other system or not, but it's the reality. So don't take it that way that I am criticizing the modern system. So but it's a reality. Most of the times, most of the investigations are done with a view of gaining some cuts of the investigations. It's not only the modern doctors, many Ayurvedic doctors also do it. So that's not a criticism only on one system, but that is the situation which we are living with. And I still tell to my students the same, like unless you have a probable diagnosis, unless you define the real advantages of the possible investigations, going for investigations is sin. And I try to be conservative, and with that kind of an approach, I'll try to deal with all that issues which we are supposed to deal with. Now, next, as far as to deal with these investigations, extra investigations, unnecessary investigations, WHO has released an essential investigation list, and you have the website there, and that gives you a comprehensive idea of the list of investigations which have to be done in a specific disease condition. And the WHO has recommended every country to have that kind of a setup of investigation list. In India, in 2016, the first essential investigation list was published, and the latest, of course, that slide, screen corner slide. Currently, in 2025, ICMR has released a new list, draft. It's the draft list which is not yet finalized. And again, I think I should not comment on the other system, but a few words about the current diagnostic list which says is a huge list of investigations, and the lists of investigations are prepared in such a way that what are the number of investigations or variety of investigations should be done in a primary health care center, secondary health care center, or tertiary health care center. And probably if you follow that, that purpose of having that possibility of non-essential investigations reduced, I don't know how it is targeted at that level. Anyway, I will not go beyond that. I will stop at that level. I will stop the introduction part now. Let me directly talk to getting to the topic now. Now, next. First part, in the beginning, I will try to how I deal with the investigations, commonest investigations, the blood picture. The common blood picture which we do is about the cell counts, different modalities of that, how it could be possibly utilized in the treatment. The first of the thing is assessing the hemoglobin level. For hemoglobin level, I think in the laboratory you have different methods of assessing the hemoglobin level. And the Anyavaratham, basically all that hemoglobin study, whatever the method you use, is about the study of that concentration of the color of the blood. So, if I say that it is the same, that hemoglobinometer is just an extension of the study of Raktanam, Anyavaratham, I think I am not going beyond that limits. Maybe bit stretched, overstretched, that's it. Now, the Ayurvedic point of view, the Panduroga, the common disease related to the blood, where there will be discolorations, they are categorized into 5 categories. Problem with us is we are not able to make out those 5 varieties of the abnormalities. We need the current investigations. Now, how I adopt to this is next. So I try to be brief. Suppose if you go for the blood investigations, of course, the common advice for the blood investigations would be total count, differential count, HB%, yes, or one set of the investigations. Or now you have the hemogram. In the hemogram, data you get would be the hemoglobin percentage plus mean corpuscular volume, mean corpuscular hemoglobin concentration, volume concentration, and RDW. That series of the data, how these data can be assimilated to Ayurvedic issue is the point there. And of course, if you go for the morphology of the study, blood smear studies, you will get the report in terms of the shapes of the RBCs, the different possible shapes of the RBCs, and size, dimensions of the RBCs. They are noted by a pathologist and they give you the information, and based upon that you make the diagnosis. So after all, what the pathologist will do is he will look at these images of the cells, study its shape or color, and then say. So we say that the investigations are objective. Is it really objective? Ultimately it depends upon how the pathologist looks at it. If the pathologist is not capable of identifying those changes in the shape, your investigation would not be useful. Clinically you do a lot of exercise, circus, and then refer the patient to a pathologist. If the pathologist is not concerned or he is not capable of identifying this, all that investigations will become topsy-turvy. So we say that investigations have made it more objective. Of course, there is an objectivity, but it is not totally objective. Claiming that the modern system is absolutely objective and Ayurveda is subjective, this is the usual criticism. There is a subjectivity. Without subjectivity, nothing can exist. That's an absolutely different issue. Anyway, next. The first of the thing is anemia. Now, anemia, the commonest disease from all our point of view. So, in the sequence, I will be trying to deal with certain of those common diseases, varieties, and so on. So, I limit focus to only that part. Anemia is a reduced hemoglobin concentration, which could be produced. Very brief, again, I am not going to pathology classes, but very brief, could be due to 2 reasons. One, the absolute, where the real hemoglobin is lesser. The relative is when the hemoglobin may be normal, but the concentration available is lesser. So the causes could be either there could be a decreased RBC production or decreased synthesis of the hemoglobin, or there could be a loss of RBCs, increased destruction. We call it hemolytic. Then, of course, other set of the anemias like deficiency anemias and so on, or in the bone marrow's ability to produce RBCs is lesser, or relative is if there is overhydration. A patient in ICU or on IV fluid, you continuously give IV fluid and then the hemoglobin level is reduced. Start with the blood transfusion. So this is unnecessary. These kinds of things do happen. So when you give excess of IV fluid, quite possible that the hemoglobin level would be lesser. Pregnancy, of course, there will be lesser. Or macroglobulinemia, abdominal globulin synthesis also is one issue. Of course, there is one more one. Go to the previous slide. The normal normal level of the hemoglobin, as per the standard, is as per the male. This is again what the universal standard. British standard would say is about male for 14 to 18% and the female 12 to 16 grams of hemoglobin and pregnant female 11. This is what the universal global standard predicted by USA parameters. But this is not universal. There is an issue which is very sensitive issue. Most of the times it's not neglected. Go to next slide. Now, just the whole thing has to be ಅದು ಆ ಸ್ಕ್ರೀನ್ ಸ್ವಲ್ಪ ಅಡ್ಜಸ್ಟ್ ಮಾಡಲಿಕ್ಕಾಗೋದಿಲ್ಲ ಫುಲ್ ಬರುವ ಹಾಗೆ. See, because that standard which is mentioned is not seen, there were a lot of revisions. WHO has revised these normal levels from periodically in 1959 for HB cutoff for adult male. So unless it was considered 14 as the normal, if it is less than 14, he would be considered as anemic. But because this is not seen universally, it has been reduced to 2024, it has been reduced to 13 grams per year. Interestingly, if you look at the hemoglobin level of the people around here, I don't think that there would be very few people who have 13 or 13 plus. Most of you, I hope, may have a range between 11 to 12. So from that criteria, all of you would be anemic. But if you go to Delhi and take the hemoglobin level, large number of people would have 13 plus hemoglobin. Now this secret, this is a very significant issue which is often not mentioned in the text. Of course, text would know about it, but not specified, and no practitioner uses it, and your pathology textbooks would not mention that increased hemoglobin level seen in urban situations. Now, in the health policies, it said that anemia is a disease of the rural area, and the supplement iron. Now, these days, anemia prevention, iron tablets are given in every school. You have blue tablet, white tablet, and so on, given regularly. Now, of course, there are anemic patients everywhere, but urban people would have a higher limit of hemoglobin level because the air there has lesser oxygen. To survive in that lesser oxygen environment, you need more oxygen. If you are living in a rural environment where the pollution level is lesser, necessarily the hemoglobin required would be lesser. And who is really healthier from your point of view? A person living in a polluted environment with higher hemoglobin level, or a person living with a natural environment with the lower hemoglobin level. So this issue is often neglected. It's not mentioned in any of the textbook, but it is a true thing. It's an absolutely true thing, and we need our policy makers to be concerned about this issue. And instead of going for that overall bullet or carpet bombing with the iron tablets, some discretion is necessary. I am not saying that iron tablets should not be given. That's not the point. But some discretion is necessary instead of overloading with the iron. Okay, anyway, next, coming to the next asset. From our data, National Family Health Survey, hemoglobin at anemia in India is very high. And the health policy gives a lot of attention to that. Data as per this would be rather year by year, it's increasing as such. That's what the survey says. And based upon the survey, you have all the policy makers and policies which are practiced. Next. Now, when a patient of hemoglobin is referred to these investigations, hemoglobin concentration and related issues, if the patient has an iron deficiency anemia, there are types of anemia, iron deficiency anemia, one of the common issue. In that condition, where you get the information would be under the microscope, the RBCs will be lesser in size, smaller in size. That's microcytic, and the color density of hemoglobin there would be lesser. That's why it is called as hypochromic. They would have a lighter color. And the mean corpuscular volume, the volume of the total RBCs in the blood would be lesser, hematocrit also would be lesser. Mean corpuscular hemoglobin concentration also would be lower. So if you have that kind of a data, it's a concern to be a iron deficiency anemia. Now when a patient comes to you, it's quite important to make out whether there is a real iron deficiency anemia or whether there is a growth factor affected, hemolytic and so on, the varieties of the anemia. So you refer for the investigations, and the investigations get the report in that kind of situation. The RDW, that red cell distribution width, is higher. That means more premature cells are being released to the circulation from the bone marrow. The production of the RBCs is faster. That's a definition of iron deficiency anemia. Iron deficiency anemia is not necessarily due to the deficiency of iron in the food. See, as the current food situation, most of the times, most of our average food quality would have sufficient iron. But the problem is the iron is not utilized properly in the persons. That's because of the dietary factors or lifestyle factors. Even if there is excess of iron, still the iron is not utilized. Patients who have real deficiency of iron are very few. Certain of those may be categories of people who do not have that some vegetables or fruits in their food asset, something like laborers and so on. They may have a real deficiency of iron, or certain of those patients who may have some disease where the iron cannot be utilized, they may have. But majority of those persons who have the iron deficiency anemia is not because of the lack of the iron, rather there is an abnormality of metabolism of the iron. Now, this differentiation often is not made out with the routine these things. But in such a condition, I would be considered this as a Kafaja Pandu, because the Kafaja Pandu, once the description is there is a Shuklatva, that paler color, hypochromic, Shuklatva, and Sushila has mentioned that Shuklatva in not only in the blood, Shuklatva seen, Shuklakshanam, Shukla Siravanadam, Tadvarna Inmutra Nakhananta, that the pallor color is seen throughout the body. Of course, as I told you, Sushila's eyes were more capable than us. So Sushila could make out that. Now we need a microscope to make out that hypochromia, the Shuklatva, and I would consider this as a Kafaja Pandu. And my treatment would be, again, I don't say that that should be the standard treatment. I think that's exactly what I was telling in the earlier also. My prescription would be in such conditions, Punarna Mandura and Ashwagandharishta as the treatment, because it is a Kafaja Pandu. Next part. So whether doshas can be identified with the investigation, that would be one of the last question to be asked. Like, so in case of hemolytic anemia, the patient would have a clinical jaundice due to the increased destruction of the RBCs and the accumulation of the globin, heme material in the body and products of heme. And in such conditions, when you see the slide of the RBCs, the slide will show abnormal shaped cells, because the shape of the cell is abnormal. That's having the fragility. Pathologies which make these abnormal cells are many different. The group of them, large group of them are there. And the sites, either it could be spherocytes, the cell could be spherical, or it could be sickle cells where the cells may have that curved shape and so on. And there is always a clinical interest. In that condition, the RDW, that red cell distribution width, would be increased, whereas mean corpuscular hemoglobin concentration would be normal or slightly reduced, and mean corpuscular volume also is raised in such conditions. That condition I would be considering as a Pittaja Pandu. Pittaja Pandu, again, you will have lot of variations, these hemolytic pathology. Again, a brief group of that hemolytic anemia. The causes of the hemolytic anemia, a good number of diseases are inherited, that there is a genetic tendency. I don't think that any genetic pathology can be cured with any medicines. So I don't suggest any curative treatment. In genetic pathologies, you need to have the same replacement possibility. There is no cure anywhere. So when the hemoglobin concentration goes below a certain limit, you need to replace. Transmission is necessary. And those are either hemoglobinopathies, thalassemia, and so on, that category of diseases which may not be amenable to any specific medical treatment. The only possibility is an alternative choice of administration of the blood transfusion. So I don't whether to categorize this Ayurvedic treatment or not, again, sensitive issue, I will not go into that part. But acquired hemolytic anemia, another group of that. Among the acquired hemolytic anemia, the commonest causes are immune mediated. patients who have immunological pathologies like autoimmune sclerosis or vasculitis. These patients may have anemia. Rheumatoid arthritis, in the long term, they may develop the anemia. In these conditions, the basic treatment for those diseases would be there, like rheumatoid pathology, I will be prescribing Kaishara and so on. But for hemoglobin, to improve the hemoglobin concentration, I would be prescribing Arogyavardhini Kumaryasava as a Agni Mandyahara to improve the Agni. And once the Agni is improved, these functions could be corrected. That's the idea of it. So it's the part, Deepana Pachana Aushadhis would be which would be the right treatment for that condition. But very specific, in case of the hereditary genetic conditions, that's not the complete treatment. Patient may benefit, but that's not the treatment. Ideal treatment has to be blood transfusion. There is no choice as such. But our non-immune conditions could be often, it could be due to drug-induced. Many certain of those antibiotics, viral infections, they may produce hemolytic pathologies. In that condition, again, the basic treatment would be you have to identify certain drugs, like the drugs which could be tetracyclines are well known to produce the hemolytic conditions. You may have to discontinue, so you know to know about the modern pharmacology and the prescribed drugs to the patient, they have to be either withdrawn or modified depending upon the patient's condition. So in such conditions, again, my suggestion to the treatment would be Arogyavardhini Kumaryasava. Of course, the description of this hemolytic anemia of Pittajapandu, Pitakshanam, Pitasiranatvam, where that yellowish discoloration seen is the characteristic feature. Now you have more advanced methods of making out. Next part. Another type of the anemia is the megaloblastic anemia, the common types. And again, I am not going to that extensive hematology classes as it, but it's only a few of the common example conditions. As we know, megaloblastic anemia is due to the deficiencies of growth factors, different varieties of growth factors, vitamins and so on. I will not go into that part. The issue is the patient would have clinical symptoms of peripheral neuropathy, tingling sensation, pain throughout the body. And then pallor is not a very significant issue. That may be or mild or bit not so conspicuous pallor. Gastrointestinal symptoms like indigestion are also the other common symptoms in megaloblastic anemia. And in that condition, when you see the blood picture, the RBCs will show a bigger size will be bigger, and hence the mean corpuscular volume is increased. But mean corpuscular hemoglobin concentration is within normal limits or slightly on the lower side. RDW is either normal or moderately higher. Now in these conditions, it's a typical feature of Vataja Pandu. So to make out Vataja Pandu, I would make out again whether that Krishna color, blackish color is seen, that's not the point. But the symptoms of Vata Vriddhi, like the tingling sensation, pain, are seen in such patients. So I would consider this as Vataja Pandu. And a good number of patients can be effectively managed with the Chandraprabha and Ashwagandha. And what I have observed is like many patients who have become resistant to the vitamin supplements, and most of the patients of that category, they come to us only after having that vitamin supplements. They may not come in the beginning. So those who are managed with the vitamin supplements, fine, they may be. I am not saying vitamins are not useful. But when a patient comes to you after having that vitamin supplement, having the diagnosis, and at that moment, one of the options of the treatment which can change the whole clinical picture would be Birechana. Once we start with Birechana and start with the Chandraprabha or Ashwagandha as a Vataja Pandu, there is a significant clinical improvement. It can be made out. But you may ask like whether all this trouble is necessary, giving some vitamin doses would be enough. Okay, fine, it may be, but you will have good number of patients where this kind of blind administration of vitamin may not be sufficient, and when they come to us, this would be a better solution. Right, next. Then the other variety of anemia is aplastic anemia, where the bone marrow growth is lesser, and that the clinical condition would be mainly the patient would be having reduced immunity, and the patient would have more recurrent infection. Most of the patients, they come to us with some complaints of infective pathology. One of the most common presentations would be what we call as pyrexia of unknown origin. Patient would have fever for a long time, and the cause of the fever is not identified, and at that time the patient may come to you. And we in Ayurvedic hospitals, you will have again a good number of such patients. where they have done all that exercise and then they come to us. And that would be the common symptoms, or patient may have recurrent respiratory infections, recurrent skin infections, which may become resistant to the antibiotic therapy. So a large number of such patients, they do end up in our setup. And in such conditions, the corpuscular volume may be normal, MCH also is normal, RW may be slightly higher, and the total count would be lesser, number of RBCs will be lesser. That's the one important issue. Size may be looking normal. There could be some reticulocytes seen in the periphery because of immature cells getting into the periphery. Reticulocytes are immature RBCs could be seen in the smear, and this I would consider as one of the asadhya part, tridoshaja part. There the patient would have jara, arochaka, sardi, etc. And these patients, the outcome would be poor, prognosis is extremely poor. I don't suggest any specific treatment. All that what we can do is some palliative treatment, blood transfusions or so on, symptomatic treatment as per the symptoms of concern. I don't think that any well-established aplastic anemia can be cured. But certain of the conditions, hypoplastic anemia, bone marrow depression produced due to transient causes, like some drugs or maybe some febrile conditions, viral toxic fever conditions, they can be managed once that basic condition is cured. But that kind of a patients are comparatively lesser. We have a large number of patients who have an aplastic anemia where the bone marrow depression, the exact causes are not known, and the series of investigations to make out that bone marrow pathology is a huge series of investigations, and the cost also is quite high. So many patients may not afford that attempt to go to that level of identifying the real cause of aplastic anemia. Before that is finalized, they may come to us. So I may not attempt further for that identifying that bone marrow aplasia like causes like. So once it is known that bone marrow aplasia, it's almost confirmed that there is no possible cure. All the treatment is valid. So I don't suggest any specific line of treatment. Depending upon the patient's presentation, we may prescribe certain of the medicines, but the outcome may not be predictable. But there is a hypoplastic situation where it could be easily managed. Now, one more condition which is now is common is sideroblastic anemia. Sideroblastic anemia is a complication of overuse of iron. Because you consume more iron than what is necessary, the excess of iron can be stored in hemoglobin. That hemoglobin would be having that extra concentration, and the cells, when you look at the cells will show that drops of iron over that area. Now, just to highlight that, I have given that outlet sun, a small image. That's exactly how it is seen. And this kind of incidences are now increasing. Earlier, in the suppose if you see the textbooks, sideroblastic anemia is not given due importance. But these days, at least some 10 patients in a year, I am seeing sideroblastic anemia patients, though the number is lesser, but the number is increasing. Earlier, very rare. Sideroblastic anemia we used to consider only textbook picture when we are studying, never seen the patient in the beginning. But these days it is increasing. Possible reason is the same, the iron overload. And in that condition, the causes of course is, as per the text, it is the alcohol abuse, iron overload as such, this is the basic issue. Alcoholism is one of the causes. Certain drugs again, mainly the iron, particularly organic iron. Inorganic iron like ferrous sulfate may not produce this, but heme products, bottles which are presented in the attractive packages, which are supposed to be the best treatment for the anemia. The patients who are prescribed the simple iron tablets, they may not like it. Ferrous sulfate is cheaper and doesn't have any attractive. When the same is packed in attractive bottles with that network and diagram of different this apple and so on, people will accept it as such very easily, or apple or liver. Many times this would have the image of the liver also, so they remember about the liver keema and then take it interestingly. Now those are the patients who have a higher chance of developing that. Organic iron is absorbed more rapidly than the inorganic iron. That's the other part. Now that's exactly what results in sideroblastic anemia. In that condition again, my treatment would be only about the Agni, next Arogyavardhini and Kumari Asava, that's the usual prescription. And if you can stop that excess of iron, that would be the best possible treatment. That's all. In very severe cases, Virechana could be the other option. Now to summarize that different types of anemia, again, this is all that what I have told, the summary, the changes or differences in the different types of anemia and how I consider Vata, Pittaja, Kaphaja as such. The iron deficiency anemia, what you see, the mean corpuscular volume, I think this is a pure textbook issue. When the mean corpuscular volume is lesser, then the serum iron, in case of iron deficiency anemias, if you go for these further investigations, that serum iron asset, there too it will be lesser, but iron binding capacity, now one of the important issue, iron binding capacity in iron deficiency anemia. If it is high, that's the real condition of the deficiency of the iron. But if the patient has sufficient iron in the body, but iron binding capacity proteins are lesser, that's not the real deficiency, where the supplementing iron would not be possible enough. So if a patient has come to the resistant anemia and you have confirmed that it is a iron deficiency anemia like features, iron binding protein would be one next level of the investigation, which can help you to resolve the issue, whether the patient really needs iron or whether the patient doesn't really need the iron. I think that's one of the basic problem which we often face. So if you have a history that the patient is taking iron tablets, fine. But if you do not have that kind of a history and you are not sure whether it's really a deficiency of iron or the iron metabolism, that IBP, that iron binding protein, would be one of the investigations which you can decide, and that the option of the treatment can be modified. And transferring concentrations also. And most of the patients who are given excess of iron after that, the transferrin concentration would be much higher than the normal. So, whereas serum ferritin in case of deficiency anemias of both sorts would be lower. So, this could be the higher level of investigations, and if you go for the next level of the investigations like bone marrow studies, which I generally don't suggest. I generally don't suggest this to the patients, but many of the patients may come to you with these reports also. In such conditions, of course, this can help you to make out that differentiation. In patients who have real deficiency of iron, it's the bone marrow iron. Now, there is another important category of anemia which we see. It is categorized in the contemporary textbooks as chronic disease-induced anemia, which looks like the iron deficiency anemia. Otherwise, clinically it looks like, but the patient would have a long-term existing disease, some or otherwise. It could be like rheumatoid pathology or patients who are on long-term medical treatment for some or other disease conditions, the patient developing anemia. And that's a chronic disease-induced anemia. It's one of the important set of diagnosis seen in the contemporary, the latest editions of hematology textbooks. In the older hematology textbooks, maybe these editions which were published before 1990, I think that word is not seen. But later, I am not 100% sure again, the textbooks which I have seen and they are the editions before 1990, that book name was not seen. But in the current latest editions of these medicine textbooks, chronic disease-induced anemia is having a lot pages, 10 pages, 15 pages, number of pages are increasing, details are more. So that's another of category. Of course, we do get certain cases, many cases of that sort from Ayurvedic point of view. And to differentiate that, there you will have all the otherwise clinical features resembling that of the iron deficiency, but the patient would have that chronic disease entity, some other. So your management will be to consider that. But differentiation there would be to make out that serum ferritin would be either high or normal in such conditions, unlike that of a deficiency anemia. That's how it has to be made out. Then, of course, megaloblastic hemolytic, I think I have already discussed that, so we'll just skip over. Next, another very significant issue is iron overload or hemochromatosis. Iron given orally, fine, it may result in sideroblastic anemia. But now another current fashion is iron injections. And patients who are administered parenterally iron injections unnecessarily again, then there is a possibility of iron load, iron toxicity. And you will get a good number of patients of that sort, where the patient would say that injection only korondulere, varagora, radvaragora. But then the pain is asking. You will have lots of joint pain. Typically, a patients who come to Ayurvedic treatment with joint pain, and these are such a category. ಹಿಂಗೆ ಪೂರ ಕೊಡ್ತೀರಿ ಇಂಜೆಕ್ಷನ್ ಕೊಡ್ತೀರ, ಅವು ಬಿಡ್ರೆ ಸಾಧ್ಯಕ್ಕೆ ಅವ್ರು ಅವನಿಗೆ ಬಿಡಾಡಿ ಅವನಿಗೆ ಬಿಡ್ರೆ ಪನ್ನಾಡಿ ಅಂತ. This kind of the situations do occur, and the variations are, the clinical presentation is quite vague. Only if you take a detailed history you can make out that cause. So that the causes could be, the commonest of presentations would be joint pain, vague abdominal pain where you cannot make the diagnosis exactly Vata Prakopa Lakshanas. Or it could be very severe like cirrhosis, diabetes also could be induced. So many times you may not be able to make out a patient in a diabetes whether it is really due to iron toxicity or not. But certain of those patients may be of that category also. Or erectile dysfunction also could be one of the consequences of that. Pranakya injection ತಗೊಳ್ಳೋದು, and then they will have these kind of issues. And in these conditions, and menstrual abnormalities, another common issues due to the same iron injections. In these conditions, I don't suggest any specific treatment, but the most important part is about stopping that iron, which often becomes difficult. Patients are brainwashed to such a level that one injection is saddiji. So this happens. So we need to many times educate hardly, very hard, and then maybe the patient may be convinced. But that's a different set of problems. I don't suggest any specific treatment. To consider it from Ayurvedic point of view, again I don't know so how to, whether he had this kind of a problem or not. No. So that's one issue. Next slide. Then in anemia patients, if at all you go for a high level investigations, genetic study is one of the important issues. If I deal with the anemia, again I will not go into the details of that genetic investigations asset, because it's beyond that average general practice point of view. If you are very much academic interested in a patient of anemia, genetic study would have a role, and a large number of genetic abnormalities are known. Most of the times after identifying the abnormal genes, nothing extra can be done. All that you can put a name plate like this is the genetic abnormality. That kind of a treatment where the gene could be modified is not yet being established anywhere. Of course, genetic modification is one of the possible options of the cure. And many of those lower middle class patients, if you refer them for the genetic studies, again the same thing which I have told earlier, like at the end of that they may not be able to take your simple medicines also. So I generally don't go into that area, but you will have patients who have that genetic studies done and with that name plates as such, and you may have the different types like Fanconi anemia, diamond black fang anemia. In all these genetic abnormalities, practically very little can be done. So all that would be supportive treatment. I don't suggest any specific treatment. I don't even categorize this from Ayurvedic point of view, like which dosha and so on. In terms of that, asadhya pandus, tidoshaja or asadhya pandus, these could be categorized. Next. Now, or another set of the disease which we see is a high hemoglobin level, hemoglobin more than normal. Among those conditions which we see now is the polycythemia conditions. The causes for high hemoglobin could be hypoxia. I think I have already given a clue earlier, like those who have a lesser oxygen concentration available to the body would have a higher hemoglobin level. Patient who have a chronic pulmonary abnormality, chronic obstructive pulmonary disorder, would usually have a better hemoglobin than otherwise a healthy attendant of the patient. So many times it happens. ಆರಿಗೆ ಕಾಯಿಲೆ ಉಂಟು, ಆರನೇ ಹಿಮೋಗ್ಲೋಬಿನ್ ಜಾಸ್ತಿ ಉಂಟು, ಎನ್ನ ಹಿಮೋಗ್ಲೋಬಿನ್ ಕಮ್ಮಿ ಉಂಟು, ನಾನು ಸರಿ ಇಲ್ಲ. ದಿಸ್ ಇಸ್ ಹೌ ದ ಪೇಷಂಟ್ಸ್ ವಿಲ್ ಸೇ. These kinds of things do you happen. That how to deal with that, that's another issue, how you communicate and so on, that's another part. Anyway, but polycythemia is one of the specific conditions which we can treat, and I would consider this as the Vata Rakta. Relative polycythemia also, that the number of RBCs could be increased in case of dehydration or diuretic therapy. In these conditions, of course, it's only about the clinical assessment. Polycythemia vera, the abnormality of the RBC production being more. Next, I would consider this as Vata Rakta, and in that condition, polycythemia vera, typically the hemoglobin level will be more than 16 milligram. If the hemoglobin level is more than 16 milligram %, that would be a cause for the clotting, abnormal clotting. That blood becomes thicker. If the blood becomes thicker, it gets clotted. And ಕೆಲವು ಸಲ ನಮ್ಮ ಕಾದಂಬರಿಗಳಲ್ಲಿ ಅವ್ರದ್ದು ರಕ್ತ ಸಂಬಂಧ ಗಟ್ಟಿಯಾಗಬೇಕು ಅಂತ. ರಕ್ತ ಸಂಬಂಧ ಗಟ್ಟಿಯಾದರೆ ಭಾರಿ ಡೇಂಜರ್. ದಿ if the hemoglobin concentration increases, hematocrit value goes beyond 60, there is a possibility of a clot formed, and the clot could be formed anywhere. Many of the stroke patients who come to our hospital, they might have been treated in some neurological centers, but they might not have studied the hemoglobin. And if the patient, and very recently I had a patient who had that all that CT scan, MRI scan, stroke, hemoglobin was 20, and I did removed the blood just a few weeks back, and that's exactly the point. So patients who have developed these obstructive pathologies, strokes, these cardiovascular accidents, peripheral ischemia, study of the hemoglobin is necessary. You may have a chance factor of seeing such polycythemic patients. When the hemoglobin is very high, hematocrit is more than 60%, blood removal, bloodletting, the thrombectomy is the treatment, that is the immediate life-saving treatment. Then of course I would be treating such patients as Vatarakta, and the Vatarakta treatment would be again the Manjastalik, Sharabasti, Kaishara, Gularogya, Orgini. That's the usual treatment. Next. The clinical symptoms would be same, like headache, dizziness, vertigo. That could be the variations in the clinical symptoms. When the bloodletting is very essential, when hematocrit is more than 40%, the usual treatment will be Kaishora, Kamaruga, etc. That's Raktapitta, sorry, not Vatarakta. Raktapitta would be the basic issue of differentiation. Right, next. Then secondary polycythemia is due to simple reasons like obesity, patients who have hypoventilation. In these conditions, I don't suggest any specific treatment. Only the thing is, if you have identified the specific cause for that hemoglobin concentration being increased, if there is a possibility of modifying that, that can be like a smoker, tobacco smoking, it can be reduced, or patients who have testosterone therapy, that can be modified. Obesity, you can't do much about, or patients who have COPD, again, not much can be done. Whatever the treatment you possible, you may give that. So I don't suggest any specific treatment for a polycythemia in these conditions. Next. Then erythroleukemia, a rare condition where the RBCs as well as the WBCs will be increased, number is increased, a sort of leukemia like. It's not categorized as leukemia, but a malignant pathology involving the bone marrow, where the erythrocyte number is very high. In these cases, the prognosis is poor. Identifying them is the important issue. Current therapy like chemotherapy, chemosuppression can prolong the life of patient much better than what we can do. So a patient of that, I would be next. I would be considered this as one of the Asadhya Pandu, Lagharaka or Alasa, and I may not intervene with the treatment. If I identify, rarely you may get such patient, I will referring the patient for a oncologist for the treatment, and definitely yes, chemotherapy treatment there would give a better result. I don't say all patients can cure, but expected life period can be enhanced beyond 5 years. A meaningful life period can be enhanced in a good number of patients. So definitely yes, in that condition, that would be a better option of the treatment. Prognosis as such is poor. Even the chemotherapy, the prognosis is poor, but it's worth. Like next. In general, suppose a patient of hemoglobin low concentration comes in, before you make out this, see that exercise of making out which type of the hemoglobin, anemia is there, the certain of the issues. If the hemoglobin level is less than 6 grams, essentially you need the blood transfusion. You will not go into the other part of the treatment. If the patient has a clinical emergency like a surgery or so on, patient has a persistent bleeding, in that condition again, you may not have the option of the treatment. You have to go for the blood transfusion. All that what we call as Rakta Prasadaka Ushadis, they can be blindly given, a group of drugs which are considered. What Sushila has suggested is Madhura, Anamla and Alavana. These drugs, they could be prescribed in such conditions. In general, if the hemoglobin is above 8 grams, in such conditions, Brahmana therapy can be suggested. Again, I have specified the treatment in the specific varieties, but still, in broader spectrum, in broader vision, if a patient comes with this and you do not find the other reasons there, that could be the option as such. And if the patient has without any identifiable lower hemoglobin, and at the range of around 10 grams or so on, chronic anemia, Shodhana therapy can be done, but not in the patients who have a lesser hemoglobin. Shodhana therapy I would be suggesting only when the hemoglobin level is more than 10 grams, but the patient has a persistent blood loss or a progressive history of anemia. I may not suggest the Shodhana in the beginning or when the hemoglobin level is lower. Only the hemoglobin level is brought up either with the blood transfusion or with other drugs, then may think of the Shodhana therapy like Vilechana. That's in brief about the anemias. The categories of Asadhya Pandu, that's about the shlokas which we have already known, like particularly those complications of the anemia which have led to the cardiac load, Andreshunam, Parihinamadhyam, Lanam Tasanteshu Jamadhishunam, that edema developing in the different areas of the body, either due to the cardiac illness or due to the renal pathology, which could be the consequence of the complications of the anemia, they are also categorized as Asadhya Pandu, and probably with only our treatment it may not be possible to treat next. The common complications which we see of a persistent anemia, irrespective of the type of the anemia, would be it results in a hyperdynamic heart, the heart tends to get enlarged, cardiomegaly, even cardiac failure could be produced. In such conditions, we will not limit only for the hemoglobin treatment. That specific condition also has a basis and supportive treatment has to be done. So I will not go into that part like cardiac function assessment and then protocol of the treatment now. Maybe in series, when if we are planning that kind of a series, maybe in the coming sequences we may think of that issue. Or patients may develop ischemic heart disease. The patient may have impaired cognition. Conscious levels also could be abnormal. Liver, lungs, kidney, etc. Target organs could be failed, and this becomes more complicated, which I would consider as the Asadhya Pandu varieties. So there in Asadhya Pandu, I don't suggest any specific line of treatment as such, but to assess the complications of the anemia, we may need a different set of investigations, modalities of investigations, which we may deal with in the coming sessions. Right? Next. The next, of course, in the blood picture would be the white blood cell count, the story of the white blood cell count. The white blood cell count, again, your basic physiology would say all that. But in general, from the clinical point of view, when the count is above 11,000, it's considered as abnormal. Normal in newborn is 13 to even 38,000. A newborn baby, it could be quite high. And in pregnancy, it's often in between the range of 5,800 to 13,200. Now, when I say this normal range, another important caution, the laboratories, different laboratories use different methods. So, standard, that normal range of blood cell count has to be correlated to the laboratory report where they give that normal value. Different methods may have different normal standard values. So, to depend upon only these numbers is not perfectly all right. Depending upon the chemicals and the set of system which you use, the numbers could be slightly varying. So, there you need to depend upon that report also and only compare with that. Right, next part. If the RBCs are increased, leukocytosis, total WBCs are increased, usually it's considered as a response to the infections. So, a patient having a acute infective pathology, the leukocyte could be raised, or it could be due to the abnormal production in the bone marrow. Very brief again, this is the simplest method of classifying that. Or it could, in case of infection, it's not that every infection would increase the WBC count. Typhoid-like conditions, the WBC count could be lesser. So, it's not necessary that every infection would have a higher levels, but reduced could be due to certain treatment. Some medicines which are given as a treatment for the infections, antibiotics may reduce the WBC count, or radiation therapy, or patients who have abnormality of the bone marrow, there again the hemoglobin, this WBC count could be lesser. Now, in brief, the commonest types of the varieties which we see would be the leukocyte count, the polymorphonuclear leukocyte count being raised. Polymorphonuclear leukocyte count raised is usually a consequence of acute bacterial infections. Most of the patients would have a febrile illness, just hit 3 times. Next. Now, yes, in these conditions, the patient would have all the clinical symptoms of pitta. Of course, if you go into the mediators of the inflammation, In case of these infected reactions, prostaglandin is released often in these conditions, and in these conditions the patient would have high fever, pain and so on, burning sensation, pus formation, purulent infections. That's exactly I would consider as pitta. Again, I don't say that every infective condition can be managed only with our drug, that I will come to that part next. When the patients would have more of eosinophil count, in that condition it's often produced due to allergy. Patient would have itching, breathlessness kind of symptoms, which I would consider the typical history of the kapha diabetic, histamine release. Again, when I say this, I don't mean to that histamine is kapha, or that's not the issue, but histamine inducing pathologies could be the kapha diabetic. So there is a lot of difference between correlating histamine with the kapha or histamine releasing diseases being considered as kapha diabetic. That difference has to be made out. It's a very sensitive point. Or patients who have abnormality of the monocytes or lymphocytes, it's always presented due to certain chronic illness, and often it could be like very chronic pain-induced conditions like rickettsia, bacteria, this malaria, etc. Collagen disorders like rheumatoid pathologies. I would be categorized as what are they? Very gross. Now, this is not a very accurate, but to a certain extent, some effort can be made out to have that vata pitta kapha identification by that peripheral leukocyte count. A lot of scope for errors, variations still are possible, so it's not very accurate, but it can be made out, the conjecture can be made out. Next, in these conditions, in a patient like infective disorders, my protocol of the treatment, when I do treatment as such, if there is a leukocyte count more than 18,000 or less than 3,000, it's not possible to manage with our medicines. And I underline that, though in the bracket the font is smaller, it's a self-demand limitation. It should be highlighted more. That kind of a limitation is defined by me only. So none of Samhitas would mention. It's not a Ayurvedic dictum. But based upon my clinical experience, if the patient has a count of more than 18,000 or less than 3,000, the alternative treatment is necessary. Maybe the modern antibiotics are based upon the condition, that selection of the treatment has to be done. So I don't limit only to Ayurvedic treatment. In general, in otherwise, those patients, it will be depending upon the real cause for the pathology. On gross, the usual prescriptions which I do in those patients who have a marginal leukocytosis within that range would be Mrityunjaya, Trifalgol, Gandhakasan, Arogya, etc., depending upon the type as such. Again, more details I will not go into that now. Maybe in due course of time we can think of that. So next, the the abnormalities of WBC count, which can be very high, and they are categorized leukemias. Among them, the quite important are the three varieties: the acute lymphoblastic, chronic lymphocytic, and the myeloid series, myeloid leukemia conditions. Their differentiation is important. Clinically identifying these diseases also become difficult because their clinical symptoms are very vague. Usually patients of acute lymphocytic leukemia, they would present with very vague symptoms like night sweat, simple rashes produce anemia. They also are presented with anemia. Some lymph nodes enlarged, but there are no other symptoms. Look like very otherwise healthy, very mild. But when you go for the peripheral smear, the counts will be in terms of lakhs or more than 40,000. That's the category of leukemia. So acute lymphoblastic leukemia, in general, the diagnosis often is totally dependent upon the initial effort to see the blood picture. If you do not see the blood picture, by simply clinical features alone, to make out that acute lymphocytic leukemia is quite difficult. I don't say impossible, quite difficult. Only when the patient has moved from one doctor to the other and then comes at a later stages, you may make out the clinical diagnosis. In the initial stages, when the patient comes to the lymphoblastic leukemia, unless you have that blood picture done, it's almost not possible to make out the diagnosis. So usually the credit of making the diagnosis would be to the doctor who has seen that patient later. Luckily we are on that position. Most of the patients, they come to us at the later stages. So that's the other way. Now anyway, when the patient is having advanced pathology, right, the diagnosis is not that much difficult. In these patients, my option of the treatment, I will be preferring always the patient to be referred to chemotherapy. because overall prognosis there is good. I will not treat the patient as a primary treatment. But after the chemotherapy, when the patient has certain complications due to the chemotherapy, post chemotherapy conditions, many times the patient may have persistent blood picture persistent blood picture abnormalities, see vague clinical symptoms of impaired appetite, debility and so on. In that condition, my prescription will be Arogya Kumari Asava asset. Outcome from the current contemporary therapy in case of acute lymphocytic leukemia is extremely good. Almost 90% of the patients would have a complete resolution. Duration of the treatment also is not very high. The chemotherapy regime, it doesn't last for more than 6 months in majority of the cases, maybe in a few cases slightly more. So I would be, without any hesitation, I would be referring to a patient of acute lymphoblastic leukemia to a oncologist for the better treatment. Later, of course, we may have some management. Next part. The other way, another is the chronic lymphocytic leukemia. In the chronic lymphocytic leukemia, again, the same issue. The clinical presentation is quite vague. Most of the times, the patient would have just a very low grade of fever persisting for a long duration. And splenomegaly, if at all is there, that would be one of the characteristic features. A patient presenting with a low grade fever for a longer period for more than 3 weeks, if the patient has a splenomegaly, most possibly that patient may have leukemia, blood picture is necessary. And in that condition, the chronic lymphocytic leukemia, the count would be around the range of maybe 80,000 to 1 lakh, and the picture would be very typical that mature lymphocytic would be, lymphocytes would be seen. Next, in these conditions, the progress would, its condition is progressive, and even these conditions, chemotherapy would give a better result. As per the current data, 88% plus have a better prognosis, but the result is not so outstanding as that of acute lymphocytic leukemia. The duration of the treatment also is quite longer, but still chemotherapy is a better option of the treatment. Next, the another is the myeloid leukemia. Again, myeloid leukemia, acute myeloid leukemia, they are mainly patients presenting with the thrombocytopenia, hemorrhagic disorders. Patients who come with the lower thrombocyte count. One of the possible conditions is myeloid leukemia. Vague symptoms like dyspnea and exertion, chest pain, etc. Our patients may even have myocardial infarction. Some of the patients have myocardial infarctions. They may be diagnosed as the myeloid leukemia later. So these kinds of issues can be there. Splenomegaly is almost a rule. So if you have that sensitivity of examining the abdomen of every patient, chances of missing that myeloid leukemia is lesser. Patient may, in the long run, they may have respiratory signs, skin infiltration, etc., which become more difficult. Next, in these conditions, the prognosis is extremely poor. Even with the best contemporary modern therapy, survival period for 5 years is just 50%. Most of the times, by the time there is a delay in the diagnosis, even the chemotherapy fails to make the outcome. So in such conditions, all that treatment could be salvage treatment. So patient coming to us, if the patient is not ready to go for chemotherapy, I would be suggesting the patient our treatment like Kantana or Arogya, not any supportive treatment based upon the symptoms. A patient can be made to feel better. I don't say that it can be cured, but still, to a certain extent, I do treat such patients with all the explanation about the possible prognosis. The outcome is poor. If the patient knows about this possible outcome out elsewhere, then we may treat that as such. And in particular in adults, the best rate of recovery as per the current data, and when I say recovery, it's a 5-year survival, is 31%. This is with the best options of the treatment, not in our condition. Okay, next part. So I will be trying to be brief about it. The other is the chronic myeloid leukemia. That again, survival period earlier was very low, but now these days, due to the new thyrokinase inhibitor drugs, the outcome has changed a lot in the new chemotherapy regime, and the 5-year survival period has now reached up to 70 to 90%. But the TKI therapy is quite costly. Many of the oncology units nearby may not have that kind of a facility. Only some advanced oncology centers have that. So if you make that diagnosis of chronic myeloid leukemia, again, the same issue. There is no question of curative treatment. It's only about the salvage treatment as per the patient's condition. If the patient is ready to take that risk, we may give some support. I don't suggest any specific line of treatment which can cure. So there is no such definite line of cure. Some of the patients may respond better, some of the patients may survive for a longer period, but I don't say that there is any definite standard protocol of the treatment as per my experience is concerned. But of course, there are a lot of claims that Ayurvedic treatments do treat, and of course, I am not criticizing that part. I am not going to that part, sensitive issue next. Then the next part about that, because we are dealing with the, I think, the hematology issues, I'll be trying to be brief. The next part of the investigation to do is about the study of bleeding time and clotting time. The bleeding time, clotting time investigation now has become almost obsolete. Earlier we used to do that. Now you have more advanced methods of assessing that bleeding and clotting, either like a prothrombin time or activated clotting time, which are the usual standard protocols done in any hospital. But belonging to the older generation, many times we still stick on to that BTCT, which is a relatively easy or simple method of investigation. So choice, of course, I don't say that you need to stick on to that BTCT. The current protocols like ACTPT also have a relevance, and they are more, definitely yes, they are more sensitive or will be useful to make out that abnormalities. Next, the common bleeding disorders. Again, I will not go into the detail. Inherited disorders. Virtually, there is no question of curative treatment. It could be like hemophilia. Hemophilia incidence has become quite prevalent now, or the von Willebrand disease, deficiency of factors. In these conditions, I don't say that any of our treatment can really produce a significant change in the outcome. All that treatment which we can do is a supportive treatment. The primary treatment that's providing that specific clotting factors which are abnormal would produce a significant outcome, though the process is costly. So I would never say that the patient has to insist on only Ayurvedic treatment. Patients who are on that therapy, if they develop any of the other complications or symptoms, we may manage. There is absolutely no risk in prescribing our drugs along with those drugs which are prescribed. I will not go beyond that. Right, next. The acquired bleeding disorders. These are the areas where we can do something in certain of those conditions. Patients with the disseminated intravascular coagulation. It's a very serious condition, of course. Suddenly there could be a bleeding throughout the body, particularly in obstetric practice. DIC is a very critical condition. A lot of patients, you might have heard many of the press these reports, incidences where a pregnant woman after delivery dies suddenly, and then a lot of chaos is there. Many of these conditions could be due to the DIC, which was not identified earlier. So very critical condition. Otherwise, in a routine clinical practice, you have very few opportunities to deal with that. But what we get would be the liver diseases. Patients have liver diseases where the patient would have bleeding tendency. In that condition, I would be preferring Chandrakala Rasa as one of the options of the treatment to reduce the bleeding as a symptomatic treatment. Then vitamin deficiency, there again it's the Arogyavardhini and Kamaduga, which I would be preferring as the line treatment as such. Thrombocytopenia, particularly ITBP, idiopathic thrombocytopenia, idiopathic pathology. We have a good number of patients of that category who are managed. I don't say they are cured, but they can be managed well with the Chandra Prabhavati and Ushirasava, and many times Pushyanaga Churna given, the Raktastambhaka Ushadis, and Manjisthavik Sharabasti given. Many of the patients have shown a significant relief, particularly idiopathic variety of thrombocytic purpura, ITBP patients. They can be managed to a certain extent. And of course, patients who are on certain medicines which can affect these blood thinners, salicylic acid being given regularly. In these patients, that could be a bleeding, but not much of an issue. So there are certain areas where we can manage with our treatment. Again, I will not go into that level of identifying doshas. In general, I would be consider these as varieties of the Rakta Pitta acid. So the options of that Rakta Prasadaka Ushadis, Shita Virya Dravyas, Kashaya Rasa Dravyas, they could be prescribed. Next, the next Now, that's about the prescriptions which I was already suggested. Next, go to next asset. Then thrombocytopenia, the common causes otherwise are bone marrow pathologies. Patient of thrombocytopenia who has a bone marrow pathology, again, it may not be within our reach of treatment. And the patients who may have hepatitis, dengue, of course, in these patients, our protocol of the treatment is not limited to only that part. The treatment of those conditions, of course, in these dengue conditions, I think very popular option of treatment which is practiced everywhere is papaya leaves, which produce a huge difference in the outcome. And along with that, my prescription would be same Mrityunjaya, common Jwara Chikitsa. And nutritional deficit, which can also produce the thrombocytopenia. In these conditions, is a Draksharishta, which is usually prescribed. Of course, rarely we get. Alcohol-induced thrombocytopenia. Withdrawal of the alcohol is absolute essential thing. Again, I don't suggest any specific line of the treatment. Thrombocytopenia also can occur due to the diseases where the thrombocytes are destroyed rapidly. Among them, of course, drugs like statins and valproic acid. Patients who have epilepsy and valproic acid is prescribed and the patient may have thrombocytopenia. Most of these times, this would not result in a critical level. The level could be somewhat at that lower level. As long as the level is less than or around 1 lakh or at the border of 1 lakh, there is absolutely no harm. Patients can manage, so there is no need of intervention. In patients of epilepsy, where the patients are taking valproic acid, there is no need of intervention. Very rarely you may get patients where the number could be very less than 70,000 so on. In that condition, modification of the treatment. Prescription should be altered, and my prescription, additional Ayurvedic prescription would be Kamaduga in such patients, which can help to a certain extent. And patients who have Purpura, again it's a typical of Raktapitta, and usual my treatment is again Chandakalarasa, Ushirasava, that would be a treatment. Pregnancy, of course, is a totally different issue, where we need to consider the whole possible conditions, possible complications, stage in which the patient has presented. So, the pregnancy-induced thrombocytopenia is a huge chapter, which I will not go into that part now. Then patients who have immunological disorders like rheumatoid arthritis, there is no specific treatment for that. The management of rheumatoid pathology with the same prescriptions which we otherwise do, it can be managed as such. And the patients who have abnormal thrombocytopenia due to the damage of the thrombocytes due to the organic abnormality, like a splenomegaly. Ultimately, in certain conditions, the cause for the splenomegaly has to be identified. There is no specific line of treatment. In some of the patients, splenectomy may be necessary. Indications for splenectomy and those options, again, is an elaborate subject which I will not deal with now, maybe in due course of time. Patients of alcohol, of course, the treatment basically is about the prevention of that. Patients who are on IV fluids long term, thrombocytopenia is lesser, and in that condition, of course, there is no other specific curative treatment. Only thing is you have to regulate that IV fluid quantities. Right, next. The next, thrombocytosis, the increased platelet count. It could be again, when it is more than 4,50,000, it is considered as thrombocytosis. And it could be due to certain acute infective conditions, acute bacterial infection conditions. Patients who have malignancies of the organs, like liver malignancies, the thrombocyte could be increased. Certain anemia like iron deficiency anemia, hemolysis also can increase the thrombocyte count. And chronic inflammatory diseases like tuberculosis also can increase the thrombocyte count. Patients who have undergone splenectomy, they tend to have a higher thrombocyte count, and there would be abnormal thrombocytes, platelets seen. Or primary diseases like thrombocytopenia, which is, where the exact causes are not known, is categorized as essential thrombocytopenia. But in all that condition, the basic issues, as long as it is at the range of 1 lakh, there is no need to intervene. Just many patients can be managed safely. If it is less than 1 lakh, then we need to have the supportive treatment. Ideal treatment in that condition is this is about higher levels, overlapping. Okay, when it is more than 4 lakhs, then only it requires a treatment. There is a possibility of clotting. If it is less than that, there is no need to bother much about it. When it is more than 4 lakh, the options of the treatment there again, from our point of view, I would be prescribing a course of Virechana. Many of the patients in that condition, the count has come down to the safer limit. Again, it's not a universal issue. Particularly patients of polycythemia vera by bloodletting, it can be controlled. Myelodysplastic syndromes, these days it's again common, where the bone marrow is marginally abnormal, the count is around 5 lakhs, 6 lakhs, not very high. In that condition, Virechana definitely produces a significant outcome. So that's about the specific, not a very specific pointed treatment protocol, but many of these patients can be managed with our treatment as such. Next. Then the other common investigational findings which we will always be seeing when you send a patient for the blood investigations is ESR. Many patients are very common. என்ன ESR வந்து raise ಆಗ್ತದೆ ದೇಖದಾಲ್ ದಾದೇಕಿ ESR raise ಆಗ್ತದೆ ಒಂದು ಕ್ವಶನ್ ಹೀಗೆ ಮೇಜು ಗುಟ್ಟಿ ಕೇಳ್ತಾರೆ. ESR is not any suggestion of any specific disease entity. It suggests that the patient has some chronic illness. ESR can be slightly raised even if you take a sumptuous meal. If somebody pays the bill and then you have the food and you get the ESR level, it will be raised at least by 10 millimeters compared to the initial level. So ESR could be raised due to many conditions. It suggests about the chronic illness. So doesn't ESR by itself doesn't make any diagnosis, but in a patient where the ESR is raised and when the patient is being treated, it can predict a prognosis, like whether the patient is responding to your treatment or not, particularly chronic disease conditions. If the ESR is diminishing, that means the patient is responding better. If the ESR is not reduced, the patient is not responding to the treatment. That would be the only advantage as such, not beyond that. Of course, the normal level is less than 15 millimeters in an adult male, and correspondingly in a newborn it's 0 to 2 millimeters. Right, next. And the clinical utility is mainly in the monitoring diseases. Again, I am not making the diagnosis, it's about monitoring the diseases like anemia, arthritis, autoimmune disorders, inflammatory disorders, malignancy, osteomyelitis, pregnancy, and so on, that whole list of those diseases. During the treatment, if the ESR is monitored, you can say like whether the patient is responding to the treatment or not. It's not for making the diagnosis. That's all the issue. There is no other specific line of treatment for that. Next. The another elder brother of ESR is CRP. When I say elder brother, again, similar thing, the information given by the CRP is almost on the same line. It's a C-reactive protein which is again a mediator of information, and that gives you the information about the possible disease conditions, status of the disease conditions. Of course, it has more relation with the tissue injury. A disease which has produced a tissue injury, CRP is more significant than ESR. Next, the last, the eldest of that series, of course, the conditions again increase, decrease, same issue like that, ESR, not much significant. Next, the eldest of the same series is D-dimer. D-dimer is, has become popular after our corona. Earlier it was not so popular. So last COVID episode, D-dimer was considered as one of the death sentences. Now, death sentence. So, the basic issue is this also is a mediator of information, and the only advantage would be when the D-dimer level is higher, there is a increased destruction of the blood and possibility of the blood clotting or bleeding. That abnormality to the blood and the hemodynamic system, that can be predicted, and hence you can predict a higher risk. That risk prediction could be more, and otherwise there is not much of a specific diagnosis entity. Of course, in a patient who is supposed to have a deep vein thrombosis, if the patient develops a pulmonary embolism, there can be a sudden raise of this D-dimer. If you are treating a patient of deep vein thrombosis, all of a sudden the patient has a lot of certain complications, pulmonary complications, and assessment of the D-dimer can exactly see like whether the patient has a deep vein thrombosis, this pulmonary embolism or not. Otherwise, it doesn't have any specific utility. It's only suggestive of the severity of the diseases. All put together, the next ESR, CRP, D-dimer, all put together, from my Ayurvedic point of view, I would be considering this as a real upastambha. Upastambha, the complications which can add on to the Vata Vyadhi and make the Vata Vyadhi complicated. Ama, that ama of different categories. And one of the basic, again, not very specific, gross issue is a patient having these higher upastamba levels, all that, ESR, CRP and so on, the primary treatment will be no snehana, rukshana chikitsa. The usual treatment protocol which we do in SDM is agni chikitsa, ksharabasti, so on. So brahmana chikitsa like snehana, that so on, that is not suggestive in that condition. It's a gross, again, exceptions could be there. So in gross, with this I think I will conclude today. It's a bit overburden, I think. Let me conclude. The last part is investigations are essential, but done with the judicious approach, they will have the real utility, and the primary responsibility of us would be to this, do this, make use of this in a judicious manner, and they should be used rationally. And to a certain extent, current investigations, they can help in modulating Ayurvedic therapy. Again, I will not conclude like whether the investigations can make out Vata, Pitta, Kapha or so on. Many people have asked me, like, when you do these investigations, have you identified Vata, Pitta, Kapha, Vyadhi? I am not in a position to directly answer that question directly, but I can demonstrate the examples of selecting the Vata, Pitta, Kapha therapies in a specific patient. With this, let me conclude. Thank you. And if there are any questions, I'll try to answer.